I'd like to introduce all of you to Dr. Matthew Eschelbach. Dr. Eschelbach is actually going to be entertaining you this evening from the Redmond, Oregon area. He is our assistant medical director. He is a lecturer on a circuit up in the Northwest Coast area. He is medical director for several response agencies, ER. He's got quite a history, and his lectures have always been very helpful. So be sure, if you haven't done it, after tonight, you can go back to the right side of the screen on PERCOM courses and click on the MD Roundtable link. And prior lectures that I remember to hit the record on, or we didn't have technical difficulties with, of Dr. Eschelbach and Dr. Frame, I have captured and posted there for you to watch as well. So keep that in mind, and you can catch up on some of the prior lectures that way. That having been said, I'm going to turn you over to Dr. Eschelbach.
All right, good evening, everybody. So we're going to talk a little bit about pediatric respiratory emergencies. And the reason that I'm talking about that is we're heading into probably the biggest season for respiratory emergencies in children. We'll start with just a little bit of a basic anatomy, and then we'll expand, talk very briefly about emergency intubation and emergency control of the difficult airway. And then we'll go back to the basics of respiratory illness. So let's get started. This is the respiratory system as I knew it as a medical student. Of course, drinking from the fire hose. This is the way that I had to know it as a medical student. And this is the airway as I knew it as a resident and what became important to me. And this is the airway as I know it today. So although the other two slides were very important, this is what I really need to know. What is my enemy, meaning the epiglottis and the esophagus, and what is my friend, meaning the larynx, and essentially the things that get infected or traumatized in between. So when we talk about beginning of the upper airway, this is about the same on every person. Essentially, you've got the tongue and then the uvula hanging down and the tonsils. And then kids tend to be mostly all tongue, and we don't see as much. But the nice thing is that most of the time, kids' anatomy is really a whole lot simpler than adults. We talk about the things that are an obstruction to managing the airway. And essentially, obstructions to managing the airway are the epiglottis that gets in the way, the base of the tongue, which we have to get past, and of course, the vocal folds and the trachea, where we're going to aim for intubation. Now, this slide kind of denotes the difference between the adult airway and the pediatric airway. If you take a look at the two, they're relatively similar, but there are some very important anatomical differences. First off, you can see the pediatric airway is funnel shaped, larger at the top and smaller at the bottom. The airway is more anterior and higher in a child, so you actually have a whole lot less area to cover when you intubate. And the epiglottis itself is floppier and kind of U-shaped, and it can get in the way. And we'll talk a little bit about a few disease states before we're done. This is a nice example of an infant airway and an adult airway. Which one would you rather hit? Well, it's all relative in actual point of fact, but the adult airway, which we get used to and is relatively standard, is about 20 millimeters wide, as opposed to that of an infant airway that's only 4 millimeters. So a lot easier to hit this target than this target. And then as you get further down into an airway that might be inflamed, you're talking about an 18 millimeter versus 2 millimeter. So this is a bullseye, easy to hit. This is a little bit more difficult. But the good news is you don't have as much things obstructing, and we'll go over that in a few minutes. This is the anatomy of the respiratory system that you want to see just before you pass the tube. So you want the base of the tongue right in your visual field. You want the epiglottis back and out of the way, and you want to see the cords, and you want to aim for the trachea. Now, in the past, with standard non-video guided intubations, this was a relatively difficult thing to see. But in today's world with video guided intubations, you should see this every time. When the tube is in there, it should occupy this area, and this is what your tube should look like. So you should see this visualization each time you're thinking about intubating an airway. But what are you looking for? So you have to know what you're looking for. So this is an amusing slide to me, a cat found, which obviously is not a cat. And someone put this up, and someone had the foresight of blocking the number out. But you have to know what you're looking for. What you're looking for is this view, and not the view of something else like the esophagus, which looks different. And when we tend to intubate in the esophagus, that is the problem that we have. What equipment do you use? Well, laryngoscope blades, handles usually 0 to 4. They're either a straight or curved. The Miller is a typical straight, which fits under the glottis, as opposed to the Mac, which kind of lifts up the vallecula and lifts up the airway by secondary intention. Adults, usually 7.5 to 8.5, females from 6 to 8. Usually we're happy anywhere between getting a 7 or 7.5 in most adults. Children are going to be different. Of course, they're going to be using smaller sizes like 3 to 3.5 millimeters. Infants up to 1 year, maybe a 4. There's 2 ways of doing this. Calculating by adding the child's 16 plus the child's age, and then dividing by 4. So if the child is 4 years old, 16 plus 4, that's 20, divide by 4, and generally we'll get a 5 tube. Of course, you're going to use a Broslow tape as well. Some people use the hand-heavy system, but the Broslow tape is pretty easy because you lay them down, you find out that they're a red or a green, and you go to your red or green bag, and that should work with them. And the diameter of the patient's little finger across the fingernail roughly equals the size of the tube. This is a rough and dirty way. Let's say you haven't got a Broslow tape in front of you, and you've got several tubes, and you need somebody to figure it out. Well, hopefully you'd have everything you need, but in a disaster mode, this would be a good way of doing things. It's not very scientific, and it's been proven to be not as scientific, of course, as Broslow, but if that's all you have, that's one way of doing it. So in the past, pediatric cuffs, relatively small, 3.5, right, or 5 internal diameter, and typically they were uncuffed, but today we have nice cuff tubes that we can give children, and they won't wind up a problem. Prior to a few years back, most all pediatric ventilation tubes were uncuffed. One other way, because children are what they are, they might have upper airway obstruction. For example, food boluses that might get stuck here. Instead of swallowing, they might get a hot dog or a peanut or a marble stuck here. We always have the cricothyroid membrane that is available in children. Keep in mind that in adults, we use the same cricothyroid membrane for a lot of our emergency techniques, but in children, it'll usually buy us about 25 minutes. You can use transtracheal jet ventilation. Keep in mind that it only buys you about 25 minutes because eventually with this method, CO2 will build up and you're not able to offload as much CO2. But just like any other child, we can use this, and it's a good emergency situation. We have these nice transtracheal jet ventilation machines. These are older ones, they have newer ones, and people tend to get different ones over time. The one that we have that we still use in emergency situations only has a metered dose to it. So as you squeeze it, it tells you based on the child's size where to go. And they're simply just a needle that looks nothing more than this, and they're fancier. These are sometimes going away from these. Some agencies are going away from these and actually doing cut downs. That is a skill that has to be acquired and one that has to be usually tested frequently. So a cricothyroidotomy, in fact, you're going below the cricoid cartilage and you're aiming for this cricothyroid membrane right there. You're not doing a tracheostomy. You're not going into the cricoid cartilage. And of course, the signs of external signs of a cricothyroidotomy are the same as an adult, although the Adam's apple will be much less pronounced in children, and you're primarily palpating that area. And of course, you can do a surgical cricothyroidotomy. You can use a quick trach or several methods where you're using a needle decompression or a needle cricothyroidotomy or a transtracheal jet ventilation. All right, so those are the emergent responses, and hopefully this is not an airway lecture. We'll have to cover that at another time. Now we're going to talk about diseases of childhood, some very common, some less common, but because we're heading into the respiratory season, it's probably better to talk about them today. If we don't get through everything today, we'll come back and talk about it next time. These are the major pediatric respiratory emergencies: SIDS, croup, bronchiolitis, epiglottitis, asthma, foreign body aspiration, and cystic fibrosis. We hope to get through most of this up till asthma. We're not going to talk about status asthmaticus today, and then we'll talk about foreign body and cystic fibrosis at a later date. What's different about a child? They're not really just a little adult, and that's what's unique about pediatric respiratory emergencies. First off, I showed you before they have a smaller airway size. So go back to the slide where you have 20 millimeters across versus 8 millimeters or 4. So smaller airways. Their normal cartilaginous aspect of the adult airway is not very stable. They're very lax. So kids have less rigid bones. They have cartilages that are softer, and their airways lack that stability that we look for. They don't have as much airway smooth muscle, so sometimes they don't get the responses as quickly as we'd like to. We'll talk about that when we talk about asthma. They have a larger amount of mucus gland density, sometimes leading to wetter secretions. They have less collateral ventilation, so they're more dependent on the lungs doing their job. Now, when we talk about hypoxemia, for example, or bradycardia in children, most of the time it's because there is a respiratory cause. Their chest wall is more compliant. It's more rubbery. The bones are not as dense. And the diaphragm structure is different. And it has a decreased number of fatigue-resistant fibers. So they're going to have respiratory difficulty. And when they, quote, crap out, unquote, they're going to do it very, very quickly. So kids have a much slower rise to having respiratory arrest, but when you get to a certain point, their diaphragm will fatigue quickly and they'll go into severe respiratory arrest a whole lot faster. So what's the prevalence of respiratory diseases? And we'll talk about pediatrics in general. If you see enough children, you'll find out that about 50% of all acute conditions of childhood have something to do with the respiratory effect. Normal child under 5 may have 5 to 6 upper respiratory tract infections and 1 to 2 lower respiratory tract infections per year. Keep in mind, anyone who has children would know that if you send them to daycare or childcare or even kindergarten, they're like little petri dishes and they come home constantly sick. The good aspect is most of the time they get micro-immunized every day against diseases. But when children get sick, they haven't seen these things before, so they might get sicker sooner. And respiratory problems account for about 2/3 of chronic diseases in childhood. We don't see a lot of chronic diseases of childhood with the respiratory system, but of those that we do see, about 2/3 of which are a problem. So the most profound and most terrible one is SIDS, or sudden infant death syndrome. When you get one of these calls, it'll usually be in the winter and it'll be in the middle of the night, and it can cause PTSD. But SIDS is the leading cause of death in infants less than 1 year of age. We don't understand it as well. We're starting to understand it more, but on autopsy, many of these infants show signs of repeated episodes of hypoxemia, and they've had this go on for weeks or months. There are several factors associated with SIDS, or sudden infant death, and the most profound of which is the maternal. If the mom is less than 20 years old, if she's not got good financial support, otherwise she's poor, if she's a cigarette smoker or she was ill during her pregnancy, and if she did not get adequate prenatal care, those are all risk factors for increasing the amount of SIDS. Infants tend to be male, sometimes premature, therefore their lungs are premature, sometimes small for gestational age, those who needed oxygen resuscitation at birth, which goes along with prematurity, and then low APGAR scores initially. These are all risk factors for SIDS. The cause of SIDS remains unknown. Primarily, it's multifactorial, meaning multiple things can cause SIDS. Apnea, prematurity is not really a predisposing factor, and there's no evidence that immaturity of the respiratory centers is a cause, and there's no evidence of a genetic link, at least not one that we have seen, but there do tend to be sometimes links in family, and we can't be more specific than that. The characteristics near the time of death, what's going on with that child just before SIDS, is usually children who are age of less than 6 months, and they peak between usually 1 to 3 months. They are more prevalent in the winter season. The children are usually asleep at night and put to bed when this happens. Sometimes they've had a mild illness approximately 1 week before death. There's no explanation or anything more specific than that. Very much there is a frequency of apparent life-threatening event. What is that? Well, a life-threatening event is when the mom brings the child or the dad brings the child into the emergency room and they say, the baby stopped breathing. And very often by the time the child gets in, we look at them, we don't find anything, but we're told to believe the parents. There are parents who are hypervigilant, and there are parents who are almost hypochondriacs, but they're usually very, very concerned. So when parents say stuff like, the baby stopped breathing, we tend to pay attention to them. And we tend to be, it kind of raises our internal radar, and we pay very much attention to that. Because at events of apnea, cyanosis, or becoming limp, enough of those to frighten the caregiver have been seen in eventual SIDS death that there is more than a casual link between these apparent life-threatening events and SIDS. This says recently, but it's been many, many years that we said the prone sleeping position has been strongly associated with an increased risk of SIDS. It's felt that it causes an increase in CO2. And we've had campaigns like Back to Sleep. And Back to Sleep is something that's easy to remember. And pediatricians are trying to push this. This is a Canadian ad, but it's a good way of saying that back to sleep, meaning you put the child on their back. Now, it's amazing how good pediatricians are doing getting this message out, because sleeping in children has changed so much. Our children went to sleep, meaning my generation. SIDS happened, and children usually went to sleep wearing light jammies, and there were lots of things in the crib, like stuffed animals and blankets to keep them warm. Anymore, children have simple sleeping attire, which will keep them warm, and there's not much more in there. Sometimes a very, very light blanket, because there has been association with putting too much on the child or having too many blankets, and children actually can be killed that way. There's also an association with children sleeping with the parents, and the parents actually roll over or go to sleep on the child and suffocate the child, which is a terrible, terrible, traumatic thing for parents. Since the cause is unknown and it happens at unexpected times, there's really no treatment for it. High-risk infants are identified based on their history, and sometimes just that history is enough for us to get that child to the pediatrician, and they get monitored for a night overnight to make sure that the child is okay. They're also trained in apnea monitoring and CPR. And it's recommended that they sleep in the supine or side position for at least the first 6 months of life. All right, moving on to the big one that will be the one that wakes you up in the middle of the night frequently for the next several months if you're on duty, or has kept ER physicians and emergency personnel awake at night for years, and that's croup. Croup is called laryngotracheobronchitis. It's a viral illness, LTB, which we know as croup. The aspect of croup that is so easily told is in the small area of the larynx, epiglottis, and trachea, because it's a tracheobronchitis, and it causes a barking seal sound. It affects the larynx and the trachea, and it's most common in children ages 6 months to 3 years. And usually, as I said, we see it in the winter months. Males are at greater risk than females. Fall and early winter is when we'll see a rise of this. And very often, sometimes we'll see spikes of this early in September when kids go back to school, and we'll see it late in the winter sometimes when there's rises in it. It's usually associated with sometimes a parainfluenza virus, types 1, 2, and 3, and RSV very rarely, but it's less so than the parainfluenza virus. RSV is respiratory syncytial virus, and the incidence varies from year to year depending upon the respiratory viral epidemic or the endemic levels in the system. Sometimes we'll see it with parainfluenza, sometimes we'll see it with RSV. And it's characteristic caused by subglottic edema and airflow obstruction. I'll show you that in just a minute. The clinical manifestations are usually a prodrome of like cold-like symptoms. Very often a child will have a little bit of a runny nose, sometimes a simple cough. But very often, mom and dad will describe to you as a barky or seal type of cough. This is characteristic. When you hear this barky cough associated with the hoarseness, you've already got your diagnosis. And very often, it'll be associated with inspiratory stridor and respiratory distress. And it's this inspiratory stridor and respiratory distress that brings mom and dad, wakes them up in the middle of the night, and that child's going to feel as if he's not going to take another breath. And the parents will think he's not going to take another breath. But rarely, if ever, have I ever seen croup that wasn't manifestly better by the time I got to the patient. I'll talk about that in a bit as well. So usually the cold progresses to a hoarseness or a cough or a barky cough. There's sometimes an associated low-grade fever. At nighttime, you get this increase in edema of the trachea and bronchi, and that leads to a little bit of a stridor. I used to recommend or put into this lecture all the sounds, and although nice, they're not always the best. What I would recommend is go onto YouTube and just write down a few things like croup, bronchiolitis, asthma, and just listen and watch those videos because they are very, very telling and let you hear the difference. A barky seal cough, the only way to describe this is exactly what it says. It sounds like a seal. Mark, Mark type of cough. And sometimes it's barky like a dog, but it's pretty distinctive when you hear it. Mom and dad will rush the child in with this respiratory distress and the cyanosis. The child looks as if he's not going to take another breath, and very often it recurs on several nights. Very, very often, what I'll tell on parents on those recurrent nights is this usually gets better with one treatment. Anymore, we'll just treat it once with Decadron or a steroid medication. But sometimes it'll stick around for a day or two. And what I tell parents is to one of two things: rush the child into a warm shower so that mist gets in there and will calm down the edema and stridor of the epiglottitis. I'm sorry, the croup, rather. And then the other thing is, very often parents will take the child, it'll be in respiratory distress and that barky cough and have that inspiratory stridor. They'll put the car in the cold car in the middle of the winter. They'll rush them to the emergency room, and the cold air actually breaks the stridor. And by the time they get to me, they feel a little bit embarrassed, and they say, it didn't sound like he was going to breathe again. And that is also usually diagnostically one of the things for me to go, this is probably croup. Oops, sorry, some reason. There, okay. So in the x-ray, in the emergency room, I might take an x-ray and look for something called the steeple sign. I'll show you that in just a minute. And then I might do blood tests, and leukocytosis is a way to say increased white blood cell count. And sometimes it could be found in bacterial tracheitis or epiglottitis. You don't want to miss these. I'll talk about them in just a few minutes, but these are not something that you can do in EMS. So here is a larynx, and this is what happens in the normal larynx. Remember, it's the airway is cone-shaped, but the larynx itself is supposed to be a regular normal caliper. But in the steeple sign, we can see that sometimes in laryngobronchitis, where they actually get the steeple sign in the whistling, and the noise is coming through this narrowed trachea. Management, usually moist, cool air and reassurance is all you need to give them. Severe croup, sometimes we'll do high concentrations of oxygen. We might monitor them with an EKG. If tolerated, if we're really concerned, we might start an IV. Racemic epinephrine seems to work better than your standard albuterol. And some ER physicians or emergency personnel use this as a cutoff as to whether or not they're going to admit the child or watch the child for 6 to 8 hours. If they wind up giving a racemic epi treatment, they will admit the child, or at least sit that child in the ER for 6 to 8 hours to make sure they're doing okay. You always have to anticipate the need to intubate and assist ventilations if it gets severe. All right, now we'll move on to bronchiolitis, the other common respiratory disease outside of croup. Usually bronchiolitis is caused by a viral infection, such as respiratory syncytial virus, RSV. We're moving into RSV season as we enter into November. So this is the perfect time of year where we'll start to see this start to peak and rise, and then it'll kind of fall off again in the spring. It causes inflammatory bronchial edema and air trapping. Incidence, it's usually seen in children less than 2 years of age. 80% of the time, it's in children less than 1 year old. And it does occur in epidemics, January through May. So we'll start to see it beginning to raise its ugly head in November. What happens in November? Well, in November, kids are playing outside less, even though this is a younger group of children. They're kept inside a little bit more because it's summer, winter time, and we don't see it as much in the spring. And they tend to group together, so they're coughing on each other. And when it reaches an epidemic, like in the daycare setting, we'll usually see it January through May. Clinical manifestations, rhinorrhea, that's a really fancy way of saying a runny nose. Sneezing, cough, fever, sometimes rapid breathing, sometimes wheezing. Now, all that wheezes is not asthma. Sometimes we'll see wheezing as part of a viral illness as well. Signs and symptoms, usually infant or a child less than 1 year of age. They usually had exposure to somebody else who had an upper respiratory tract infection. It's usually very gradual in onset. You can sometimes wind up with an expiratory wheeze, and you can get tachypnea up to 60. This is the kid that's scary. This is the kid that's breathing so fast, and his work of breathing is so hard that you want him admitted to a place where nurses and pediatricians can intubate that child right away if they need it. Sometimes cyanosis will happen as well. The treatment essentially is fluids, antipyretics such as Tylenol or ibuprofen. Oxygen can be used, and then temporarily they can use bronchodilators like albuterol, and sometimes steroids are given. Usually this is under the care of a pediatric intensivist or hospitalized pediatrics ward. You can also use humidified oxygen, just like you would with croup. You're going to want to monitor these kids because you want to make sure that they don't go into bradyarrhythmias or tachyarrhythmias. IV sometimes just in case you have to do intubation or you need to control the airway, or you might need to give antibiotics if they develop a pneumonia. Bronchodilators such as albuterol or our standard, Atrovent or Duolneb is also possible. And then always anticipate the need to intubate and assist ventilations if it gets severe. The relationship to asthma, is there a relationship to asthma? And it is incidental. There's a high incidence of 30 to 50% of the patients with bronchiolitis during infancy will go on to develop asthma. So does the viral illness cause asthma? No, but of the kids who are going to develop asthma, about 30 to 50% of them have had bronchiolitis in the past, so there's a higher susceptibility. Asthma versus bronchiolitis. Generally, asthma, these are generalizations. Age greater than 2 years is usually not a fever. There's a family history of asthma. There's a history of allergies, and usually they respond to epinephrine asthma. Bronchiolitis is usually kids less than 2 years. They usually have a fever or some type of viral illness at a time. Family history, other than exposure, is negative. Allergies are not a problem, and response to epinephrine is usually negative with bronchiolitis. All right, we're going to move on to epiglottitis. Epiglottitis is a bad player. It's usually an immediate life-threatening, possible complete airway obstruction can happen with this. Usually it's respiratory distress with a sore throat and drooling is diagnostic in and of itself for epiglottitis. And it's usually caused by a bacterial infection such as Haemophilus, which affects the epiglottis and the adjacent pharyngeal tissue and causes a supraglottic edema. Now, the good news we saw this going down for years and years and years, and you've heard me talk about anti-vaxxers before, people who don't immunize against the normal childhood diseases have a higher incidence of this, and this not only Haemophilus influenza, not only does it cause bad ear infections, it can cause epiglottitis, and it can cause airway compromise and even death. So when you get an argument from an anti-vaxxer saying, I don't believe in them, they're bad, they cause autism, etc., my argument is usually, listen, let's go after the bad players, and if you don't want to immunize your kids against something like the possibility of an infection from a GI bug, which is common, like a rotavirus or something, fine. But let's get measles, mumps, polio, tetanus out of the way, the ones that will kill kids, and Haemophilus is in there as well. and they can lead to complete airway obstruction over time. This is a life-threatening upper airway obstruction caused by infection of the epiglottis. Generally occurs in children between 1 and 5 years of age. The pediatric incidence has fallen due to the Hib vaccination, but because we have these pockets of people who believe that vaccination is bad for you, it's on the rise again, and children are starting to die again. It can occur in adults, particularly the elderly. Because these people were never immunized against Hib as children, they probably developed some form of Hib, that's Haemophilus influenza infection, and over time they've lost their immunity, and we can sometimes see it in adults causing similar symptoms. And we do see it more often in adults as people who were not immunized as a child are starting to turn older and maybe losing part of their immunity. This is a very typical vaccination schedule where you kind of go against the things that are big, like hepatitis. Like I said, rotavirus, okay, I can live with that. Tetanus you can't live with. You can't live very well against Hib. Pneumococcal, okay, if you don't want to do it, wait for something else. And then MMR, varicella, hepatitis A, all these things. These are discussions you have to have with your pediatrician. Not you, but any child, parent of a child. Epiglottitis will usually give you stridor. Now, the difference between the stridor of the last infection croup and this stridor is very, very distinct. It's usually a rapid onset and progressive. It's usually a high fever, and you get a muffled rather than a hoarse voice. And that child kind of has to lean forward and can't swallow. So they refuse to eat, drink, or sleep. They prefer to be sitting up, and there's quite a bit of anxiety because they feel like their airway's closing off. As I told you before, with croup, by the time they get to the ER, they're usually better. That's not the case with epiglottitis. They just continually get worse. They will sit there and have this appearance of as if they're not going to take their next breath, and the stridor is pretty evident. Usually it's rapid in onset, and they go from normal to severe distress in just a few hours. High fever, sore throat with the difficulty swallowing. Drooling is very, very common when they'll lean forward and they can't handle their secretions because the drooling is so bad. They'll have stridors, breath sounds. They'll have to lean forward. This is very, very uncommon. If you try and put these people back and lean them back on their mom or on their dad, or maybe on a stretcher, they won't do it. They have to sit forward with their neck slightly extended. And sometimes they'll present, up to a third of them will present unconscious and in shock because their edema is so bad in their upper airway. You want to give high oxygen as much as possible. Get an IV going if possible. Rapid transport to somebody who can handle a pediatric airway. So you might have a protocol locally that there's no pediatricians in your hospital, and the next town over has pediatricians, and it might be worth the time to get them there. Don't attempt to look in the airway, because one of the keys is if you touch that epiglottis and you disturb it, it can get quickly edematous and get worse. Usually we'll do in the ER, we'll do a lateral neck x-ray. We'll look for what we call a thumb sign. I'll show you that in just a minute, of the epiglottis where it's inflamed. And then we might see a direct observation of an epiglottis, and the supraglottic areas of the mouth usually will call anesthesia in right away, including an ENT surgeon and an anesthesiologist, because we're going to want to get that kid ready for intubation. This is a lateral neck x-ray, and this is what we call a thumb sign right here. The epiglottis is usually very thin and not visualized, but in these kids who have the stridor, if we get what we call a thumb sign where the epiglottis is enlarged, we know that we're dealing with potentially difficult airway right away. Treatment is usually intubation for at least 48 to 72 hours. There is a good argument of doing this quick and early. And of course, if there's a viral cause, just watching the child. If we can prove that there is a H influenza or suspected H influenza, we're going to treat them. All right, in our last few minutes, we're going to hit asthma. And then next time, we'll try and get some of the finer points of asthma, such as status asthmaticus, but we'll just talk about asthma in general. The pathophysiology of asthma is it's a lower airway sensitivity, usually to allergens such as dust or infection, irritants such as very often asthma is an inflammatory disease, so it could be something as cat dander, cat dust, mite dust, any of those. Emotional stress plays a certain amount of role in emotional stress, but you can't rule that out alone. Sometimes exposure to cold, sometimes exposure to exercise. And they used to do something in the old days. They would take a normal lung and then they'd spray in an irritant and they'd see if it caused asthma-like symptoms. And let's say it was cold air, and then asthma symptoms, cold air is linked to it. But over time, we found people had something we call reactive airway disease. Asthma is a reactive airway disease, but it depends on what the irritant is and whether or not somebody is susceptible to it. So most of the time, asthma is a full-time diagnosis, and people who have asthma deal with it every single day, usually from allergies or irritants. But there are folks who get certain viral infections who have asthma-like symptoms, and then once the cold is gone or the virus is gone, their asthma symptoms disappear. And to those people, we say it's a reactive airway disease. I know it's a fine line, but they don't need asthma medicine all year round. So we think of asthma as a triangle. There's bronchospasm, that's what causes the wheeze. And then we get bronchial edema, which makes the bronchospasm worse. And then we wind up with increased mucus production. So all three of these, edema, bronchospasm, and increased mucus production, will lead to the clinical scenario of an asthma attack. Here on the left is a normal airway, and we know that we've got muscles inside or just outside the lining, and if those muscles contract and we get inflammation, this is where we go from a good airway to a smaller airway, and then now when we get mucus plugs, we've got an inflamed airway. So what do you do when you whistle? If you were just going to make an O sound, you'd have this nice O sound. But if you purse your lips and decrease the size, you come up with a whistle. And that's what's happening in your lungs. Normal airway, muscle contraction, a few mucus plugs, and before you know it, we have a whistle that we know as a wheeze. This is a cast of someone who had bad mucus pluggings. So what they did in this particular symptom is this person, this is post-mortem, of course, These are the smaller airways, and people had severe plugging, and they were able to actually add a rubbery material to the already dead lung, and they could see where the casts were formed. Asthma's most common chronic disease of childhood. 5 million kids a year under the age of 18. We do see an increase in asthma over the years because there are more irritants in the air. Usually 1/3 get it before 2 years of age and about 80% before 5 years of age. Males outnumber females with asthma in childhood. Clinical symptoms of childhood asthma. Precipitating factors can include a viral infection, allergens like food and inhalants. This could be a dust or mites, for example. If you talk to allergists, the first thing they'll tell you to do in a kid's room is take out the stuffed animals and see what could possibly be irritating the kid's lungs. Sometimes exercise-induced asthma can cause a bronchospasm. Chemicals, pollutants, environmental changes, hot or cold, emotions, we talked about those already. Sometimes gastroesophageal reflux, what you might call heartburn, can cause asthma symptoms in a kid. Sinusitis, and of course, exposure to drugs. Usually the signs and symptoms are shortness of breath or dyspnea, nasal flaring, and you get tracheal tugging. You can see these kids, you want to observe these kids with their shirt off, and you'll see the accessory muscles being used. And then you'll see also suprasternal, intercostal, and epigastric retractions, and that means a kid's struggling for air. Coughing, and the most common is expiratory wheezing is common. Tachypnea, which just means faster than 16 breaths per minute. And cyanosis can sometimes occur where kids get blue. Prolonged attacks are susceptible to an increased water loss because they're breathing quickly, and they can get dehydrated because as you breathe in and out, you're letting fluids in and out of your lungs. Decreased PO fluid intake, so if you've got a viral illness and you're not taking in as much water, it could put you at risk for a prolonged asthma attack, and of course, dehydration. So when you're taking the history, how long has he been wheezing? Did it just start? Is this something that's similar to what they had in the past? Have you been eating and drinking normally? Have you had a cold recently or recent upper respiratory tract infection? Do you take medications for this? Do you use an inhaler? Do you not use an inhaler? Is this a new medication? Do they have allergies normally? Are they allergic to the dog and to the cats or to dust? And have they ever been hospitalized before? This is a very, very important question to ask because it's kind of a prelude to what you might have to do. Very often, mom and dad will tell you, oh yeah, he's been intubated 4 times. That's a bad thing. When you do a quick physical exam, what's their position? Are they leaning back? Are they retracting like we talked about? Or are they leaning forward? So maybe this is something else like the epiglottitis we talked about. Are they drowsy or stuporous? These are not kids who are asleep, but if the kid is awake, is he falling asleep on you? And is that the beginning of hypoxemia? Are there signs of dehydration? Sorry. Is the chest moving symmetrically, or are they starting to use their intercostal muscles? And what do their breath sounds sound like? Have they been in the ICU before? Have they been admitted before? Have they been intubated before? Have they been in the emergency room more than 3 times in the past year? Have they been admitted to the hospital before? Have they used more of their medication in the last month than normal? And do they use steroids on a regular basis? Now, steroids in children are usually in the inhaled form. unless the kid has very, very bad asthma, they're not going to be on prednisone. But very often kids will use bronchodilators that have a steroid component. And are the symptoms getting worse despite aggressive treatment? So if the kid's wheezing more, he's at higher risk. Silent chest is equal to danger. So if a kid's wheezing and you give him treatment and he's better, great. But if he seems to be getting worse and you hear all the wheezes go away and you now have a silent chest, be careful, because that's the step just before respiratory failure sometimes. The golden rule with asthma, all that wheezes is not asthma. It could be pulmonary edema, rare in children, but possible, an allergic reaction. It could be pneumonia. Could be foreign body, which we'll talk about next time. And sometimes wheezing is something else. It's not wheezing, it's stridor. We're just not listening correctly. Management, ABCs, right? Airway, breathing, get them in the sitting position. Humidified oxygen, if possible. If they need a non-rebreather, you can give that to them. Encourage coughing. Consider intubation and assisted ventilation if the child's not getting better. Most of the time, you should start an IV just in case you need it. Assess them for dehydration. You know, give a little pinch to the skin to make sure that the tenting goes back where it's supposed to. If they need fluids, you can give it to them tenaciously, and watch their EKG, because if they go into an arrhythmia, you want to know that right away. Obtain their medication history as much as possible. Did they take something else, and do they have a problem with their heart rate? And usually we use simple albuterol. Terputylene, propranolol, isoethane, these are all older things that we don't see as much. We do see a lot of albuterol, and we see a lot of albuterol mixed with duoneb, and a duoneb is fine. Atropine and ipratropium are both anticholinergic drugs, the most common of which is ipratropium, and that is the other aspect when we talk about albuterol and ipratropium. We know it now as Combivent or duoneb. That's the most common. This albuterol works on small airways, and ipratropium works on larger airways, and they're fairly common together. If the kid's really getting bad, we can give some epi. You can give terputylene. That's not used much once in a while. We still have it sometimes hanging around the ER. If the kid's not getting better with epi, we'll sometimes try terputylene. You have to outweigh the risks and benefits. You know, I'd rather give epi than have a kid go into ventilatory failure. Be very, very cautious when giving two simple sympathomimetics to the same patient. That means you're giving them epinephrine and something else, such as the albuterol, and the two of them together can sometimes cause a tachycardia, and it can be hours before that kid slows down. So you want to monitor that patient and watch their vital signs. Avoid sedatives. You don't want to depress their respiratory drive, so you don't want to give kids things like Valium or Ativan or midazolam to calm them down. Antihistamines can decrease their level of consciousness. That's Benadryl and things like that. And do not give aspirin, high incidence of allergy. I don't think you're going to see this as much, but aspirin has also been tied to Rise syndrome, which we sometimes see with kids with colds in the middle of winter. And we're right at 7 o'clock, and that's it for part 1 of respiratory problems. I'll entertain any questions. and then we can go from there.
Yes, Sarah, I have a question. It's Randy. I was wondering why the incidence in most of these diseases in children are higher in males than females.
You know, that I don't know. Only it might have something to do with recessive genes, but I don't know why males are higher than females.
Okay.
I haven't got a good epidemic or I don't know why.
Okay. Thank you.
But we do see it also, we'll see it very often more in children who are city-born or city-raised because the air is less clean in cities than they are in countries. And it seems kind of funny, but it depends on the time of the year. In certain places like Iowa, the Midwest, corn silt in August, September is floating through the air terribly. And if you have an allergy to that, you'll see an increase in respiratory distress in kids that time of year. In the wintertime, there might be more soot and there might be more non-clean exposure, fossil fuels that are broken down less. So in cities, the higher pollution rates, you'll see that as more. And the word is epidemiological. There we go. Thank you.
Thank you.
For intubating a child, is there any advantage to using a bougie versus a rigid stylet, or is it just personal preference, do you think, for providers?
I think everything with intubation is a personal preference. It's what you feel comfortable with. Keep in mind that bougies for kids are thinner and more pliable. Things that we call coat hangers or things that go into the stylets are usually more rigid. Most of you are trained in video-assisted intubation, and you don't need it as much in kids because they have shorter necks and you can see things a whole lot better. So even though you're using smaller equipment and tinier things, intubations can some guys go easier with kids than with adults. Adults tend to get big, bulky necks. They tend to be fatter. They have bad teeth or dentures and stuff like that. So pediatric intubations are usually simpler, and it's whatever you're used to. So my best advice is when you're training to do your pediatric intubations, even if it's a mannequin, try every tool in the box.
Thank you.
So I think my question is kind of answered by your answer right there. I was going to ask you kind of which is your preference between an LMA or intubation? Do you think, like, if you're just comfortable with one, go with that one? Are they kind of similar?
Well, it depends on what you're doing. LMA is never a definitive airway. An LMA, whether it's an iGel or an LMA true laryngeal mask, or even a king tube, are not definitive airways. The only definitive airway is intubation, where you actually watch the cords and watch the tube go through the cord. But rescue airways, there are really good rescue airways. In fact, we have a rescue airway for infants, and it's about an LMA that's about as big as a spoon, and it's tiny and it's not disposable. We use it very rarely, but it buys us time. Keep in mind that, this is an old adage that has to do with wilderness medicine, but it's very, very true. You can go about 3 weeks without food, about 3 days without water, about 3 minutes without oxygen, and about 3 seconds without coffee. So That being said, you've got about 3 minutes before you start to lose brain cells. So these, in a pinch, use an LMA to rescue the airway until you've got everything you need for a definitive airway. Does that answer your question? Okay. Any other questions out there?
Yeah, I've got a question. If you have a patient having a prolonged asthma attack and they're not responding to the bronchodilators, and you have both epi and terbutaline on hand, which would you push first?
I would use epi first. Terbutaline is relatively rare these days to see it. It's an old OB drug, but sometimes it's something that I'll pull out. Most of your airway pathways for bad asthma, you'll go down a different pathway. You'll go down mostly, as we said, with bronchodilators, and then sometimes lidocaine will go in there. Magnesium could go in there. Some people will use something called Heliox because helium is supposedly lighter than air and will get into those smaller airways. So if I would go with our dosed, it's okay to go right away to a duoneb. There's been some controversy over that, but you can go with a duoneb. And then after 1 or 2 treatments with a duoneb, which is, albuterol and your ipratropium, I would go to a continuous nebulized Ventolin or albuterol. And then if that was getting worse, I would go to the epi, and then I'd start considering, is this kid going to need to be intubated? And then you can start talking about things like magnesium and all those things. So hopefully by that time, you've got some form of airway rescue going on, and you're closer to the hospital.
All right, thank you very much.
Doctor, I have a question. What about using magnesium sulfate, muscle relaxant, after you have exhausted your use of bronchodilators?
Right. Well, that's, like I said, it depends on your protocols, and that's on our end of our protocol. Usually, magnesium, of course, as you said, is a muscle relaxer. Where we use that primarily, magnesium, we'll see it in irritable heart conditions. We'll also see it used when people have an irritable uterus. We'll use it for seizures during preeclampsia. But because it also relaxes smooth muscle, it's kind of at the end of our protocol for bad asthma. So if I'm at that tipping point where I'm considering, boy, am I going to intubate this person or not intubate this person, I'll try magnesium pretty early on. Maybe at the same time that I'm intubating somebody, but usually we'll do the continuous nebs and watch their end tidal CO2. We didn't talk about that, but make sure that the end tidal CO2 is not climbing, and then you can use magnesium as a muscle relaxant in addition to the bronchodilators.
Thank you, doctor.
All right, well, I guess that's the end of our questions. Next time we'll talk about status asthmaticus, which we kind of hinted at the end. And we'll talk about foreign body, and we'll approach a few more diseases. All right, thank you everybody for participating, and we'll see you next time.
Thank you.
Thank you.
All right, you're welcome.